Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast here at Countryside Equine Hospital, back in the studio this morning. One of my favorite places, the old treatment room where we save lives and make dreams come true, you know. Mm-hmm. So, Dr. Brown's back with me. How you doing this morning?
Doing good. We're here.
You know, rocking and rolling.
We're rolling.
You've been in the heat of dental month this month, right?
Oh, man. It's nice to do something that's not a mouth, so...
Telling you, it's been a little float-a-palooza. These floats are starting to wear out.
There's so many. Oh my gosh, we've had a lot of dental casualties. Already had one float have to be maintained already this month. We're like a week in.
It's gonna happen.
I know. It'd be like that on them hard jobs.
It'd be like that on them hard jobs.
We're here. So, it's like 80 degrees today. It's great. It's like
fantastic.
Summer. Oh, it's nice.
You know, I had a friend of mine. He was in town helping us out with a meeting, and he's like, "Damn, why are so many people moving to Georgia?" I was like, "Jim, it's 70 degrees in February. This isn't terrible. It doesn't suck.
It may not stay like this, but
no,
we can enjoy it while we can."
Yeah, I mean, that's my thought. Enjoy the good days.
Mm-hmm. Why not?
So. Well, speaking of good days, how about that segue?
Oh, I was like, where is this gonna go? How are we gonna get there?
You know, here we go. Speaking of good days, we're going to talk about endoscopy today. Mm-hmm. And endoscopy, you know, used to when we thought about endoscopy, we thought about, you know, upper airway scopes. You know, can your horse breathe? But, you know, a lot of the advancements in endoscopy, we can look at so many things, and we're going to talk about, you know, the different techniques we use, the role endoscopy plays in veterinary medicine. Yes,
and how accessible it's become now too. Because I think we've talked about this in, you know, when you were in vet school back in the dinosaur times.
I mean, it wasn't that long.
You know, the endoscopy was this big tower that got pushed around the hospital, and now it's on an iPad.
You know, what it used to remind me of was, well, y'all probably don't know what this was, but when I was in elementary school, you had the AV cart.
Yes.
Do y'all remember that?
Oh, yeah.
It was that huge tower with this TV that weighed like 900 pounds.
Mm-hmm.
And it was strapped down with like a ratchet strap so it didn't fall off.
Yep.
It was this massive tower that you'd roll the VCR in. Mm-hmm. And if you're listening to this podcast, you don't know what a VCR is.
You're too young for this podcast.
You're too young for this podcast. But yeah, there were these huge towers, and they were the portability. Like, it was barely portable within the hospital. Like, getting room to room could sometimes be a challenge. But they were massive units, and we were sort of limited on what we could do.
And I feel like probably most hospitals, if they had one, they only had one. Would be my guess. They probably had a 3 meter and a 1 meter.
Right, and the 3 meter was sometimes a stretch. It was very few. I remember when I bought my first set of scopes, I bought a 1 meter and a 3 meter. You know, now we deal in 3.5 meters for gastroscopes, but back then 3 meter was big dog in it. That was all we had. And I can remember it was one of the first endoscopy units in the state outside of the university.
Really? Mm-hmm. Wow.
It was not
pretty
common.
Cool stat.
Because like I said, there were these massive units. And so if you didn't have a hospital, it wasn't much good to have an endoscopy set.
Right. So. And now with where we are, I mean, like we said, we have what, three units?
Yeah, 3. Well, 3.5, because number 4, she's on the way out.
She's on
the way out. But the advances in technology and the image quality is remarkable. You know, used to you were dealing with these massive tower units in order to get a decent image, and like I said, we can get a decent image off the iPad system that broadcasts wirelessly.
Yeah.
That's our half unit, and I'm missing the fact that it's...
I love her. She's great.
She's fantastic.
5 minutes in and out, you got it. You're done.
Now the company decided not to make it anymore. Oh, it's terrible.
It's very sad. Sad time.
But, we got a new system out that we purchased this year. And, I was actually using it yesterday. And everybody that's seen it, their reaction is always the same. Like, wow, that's really clear.
It's a really nice image. It's a really, really good. And it's almost as good as the big tower one that we do have. Right. And, but it's a lot more portable than that one.
A lot more portable. And it actually reminds me of some of the original Olympus tower scopes. Mm-hmm. Now those have gotten better, but it's incredible, the processing power.
Yes, and it only takes less than 5 minutes to completely set up and tear down. It's great.
It's pretty amazing.
And I think that's one of the big things that clients are always, I think, surprised to hear from us is that we say, oh yeah, we can scope you on the farm. Mm-hmm. That's no problem. Yeah. They're always like, wait, really? You can do that? I'm like, oh yeah.
Portability.
Mm-hmm. It's like, as long as I got power.
And it's become more and more convenient over the years to be able to do that, and it's a great service that can be offered. And there's still some endoscopy cases we like to bring in, yes, because of the more or less the technique and having the things we need. But a lot of this can be done on farm. Mm-hmm.
And we can look at a lot of different structures now. I think, like you said, it probably started off as airway was probably the big thing that they were doing, was on the racetracks looking for roars.
Well, I can remember my first scope was it did not have a camera to it. You look through a little eyepiece.
Oh yeah, the little telescope. Yeah. Mm-hmm.
And you had this, and I remember the guy that taught me, he had this big light source that you had to. It was almost like wearing a backpack, right? Mm-hmm. You had to put this backpack on, have it tucked behind you, and then that was the light source, so that you could then. You trained under the same guy, and you could look through the little eyepiece, and
there you see it. And there's their little airway, just open it up.
And mine had a little tiny light source I could fit in my back pocket, and it was pretty cool. Mm-hmm. Still got that scope.
You still have it?
Still have it. Mm-hmm. Still pull it out on occasion.
Just to flex on people and be like, we can still do it.
I can still do it. I still got those skills.
That one you could do that one-handed, though. The ones that they have now, you can do it one-handed. I had to do an airway scope a couple weeks ago, and I was having to one-hand it because the horse just needed two hands on it, and we were real people limited. Mm-hmm. And so I'm driving and passing at the same time, and I'm like, oh Lord, here we go.
I have I've done many of them that way.
Mm-hmm. But yeah, you can do it. Now we've kind of learned that if there's a hole, we can stick a scope in there.
You're not wrong.
Mm-hmm. I scope bladders. I put it in mouths.
I forgot even about, we got oral endoscopy.
We have an oral scope, yeah, so.
It's one of my favorite tools to pull out and use.
Guttural pouches, we've done a lot of those.
So let's talk a little bit about indications and techniques. I think the first one that I think about is airway scopes. Mm-hmm. That was probably where I think that's where it all started, we're going in to look at airways. And, these are horses that are making a lot of noise when they're breathing. Exercise intolerance is another place I'll usually pull out my scope. Mm-hmm. Chronic coughs. And there's a lot of indications, but the biggest one was that labored breathing, chronic coughs, poor performance.
Right. And there's kind of two different flavors of it, I guess. We have the resting airway scope where we're just standing and looking at them, and it's best to try to do it unsedated if we can. It has to be the right horse and the right circumstance. Sometimes that's one where, sometimes it is better to do at the farm because they're more comfortable. Sometimes they're here and they're a lot more wild up, and it's easier just to stick it in there and do it, because if we're looking at the airway and the function of the airway and how that opens and closes, sedation is going to affect that. Hugely. And so we really try to do that with as little sedation as possible, so we can actually see is the airway moving the way that we need it to. Is there, if they're coughing, are they, I've seen some that they displace a lot, and we have a lot of horses that will displace their airway, which is where their soft palate will kind of rise up and trap all the structures, and that can happen sometimes if they're too sedated, and that doesn't really mean anything. But if it's happening while they're not sedated, that could be a thing. Mm-hmm. I had one that we were looking at it, and the horse we actually went in for a gastroscope because the horse was just getting real weird under saddle, and I stick the scope in there. We're about ready to get the horse to swallow us, and I'm looking at the larynx, and I'm like, something's not right here. And this horse's epiglottis wasn't trapped. And I'm trying to get him to correct itself, and it's not. And of course, the horse was super sedated at the time, so I was like, well, we're going to have to come back here and do this at a regular time. But I think I went and I showed you the pictures, and you're like, well, that's why this horse is freaking out.
Yeah.
It's because every time he gets going, his epiglottis gets entrapped, and then he can't breathe.
Yeah, because he had the ulcerations. Around
Yeah, he had it was like everything there. I was like, what in the world is going on? And but it all made sense, and he got that corrected, and behavior got better.
Well, I think it goes back to, the one thing they told us in vet school, and most of our mentors beat into us, is you miss more not looking than not knowing. And I think that's where endoscopy comes in, is you're looking.
We're looking, yes.
And like you said, sedation, that can cause a lot of artifact. One of them is if we're suspect of a horse that's a roar, or what we call left laryngeal hemiplegia. Most of the time when you sedate these horses, the arytenoids get really lazy, and it can look
like a roarer.
Right.
We have some that look like it, and I'm like, well, they're heavily sedated, so I can't really write too much about that. But when we do have these ones that we're looking at it, try to do it without it. And then kind of the other half of the airway scope is the dynamic scope, which is
those are cool.
Those are fun.
I keep. That's one of the things I really want to add is the dynamic endoscopy, but it's hard to find a company that will stay in business long enough.
They're very technical too. There's a lot that goes into setting them up. So basically what it is, it's a big kind of head harness, I guess, and it has the scope directly attached to it. So you put the horse in it, you get the scope in place, and it's looking at their airway, and then you go and lunge them around or jog them, and you watch how their airway moves as they're exercising, and it's so cool to see. It is.
Because there's a lot of things on the upper airway that we can't get on a resting scope. Sometimes we'll try to induce some things by, occluding the airway, holding off the nostrils, try to increase that pressure to get us to see it. But sometimes we have to go to that dynamic endoscopy, and I think it's definitely, I keep trying to pick one out, and every time I get ready to, they quit making that one. But
the one that we had at Southern was very old. It was very old, and I think they were very careful with that thing, because I think they knew that if it broke, it was going to be really hard to have to try to maintain it.
But yeah, that's another aspect of endoscopy is, if you're having trouble at work, you can put a scope in there and actually watch these horses exercise. When I was in Kentucky, we used to do that on a treadmill.
Oh, yeah.
We had this massive horse-sized treadmill. To give you an idea how big it was is, well, you know what, they can't really fire us now, but we got in there messing around with it one day, and I think we had 5 people jogging on the treadmill at once. It was like group exercise.
Oh, yeah.
But yeah, we broke in, turned it on, and
didn't get it all the way up to 40 miles an hour?
No, we didn't make it that far. So yeah, dynamic endoscopy is a huge help trying to figure out what's going on with these airways. And and the other thing is, when we're talking about airways, is being able to get evaluation of a lower airway.
Yes.
We can drive the scope right down the trachea. And, I did one just yesterday, got down the trachea, and I had a lot of mucus down the lower part of this airway. And so we were able to do what's called a transtracheal wash, which is where we can actually go in and get a sample from the lungs that can tell us what kind of cells live there. We can look for bacteria. We can get cultures. There's just so much information we can get from that procedure. And that's the other beauty of endoscopy is when we talk minimally invasive, this is about as minimally probably X-ray and ultrasound are the most minimally invasive, and endoscopy is a really close second. So
very easy sedation, in and out. It doesn't bother them nearly as much.
It really doesn't.
That was my always big thing that I think I was the most nervous about trying to do those. I was like, oh, they're going to be in their trachea, they're going to be freaking out, and once you get in there, they stop coughing, and they kind of sit there, and you can flood them with the saline and get it back out, and they do just great. And you get some really good diagnostic information from that.
If you're trying to figure out, are we dealing with asthma or pneumonia, transtracheal washes, BALs, hands down best diagnostic tool we have.
Yes. Bleeders too. We can get a lot of information about that as well. If they have a lot of red blood cells in there and we're trying to figure out if they're really actually a bleeder.
Yeah, especially, I mean, there's a lot of these barrel horses I'll look at the day, I try to look at them like the Monday after a weekend of running, and I can go look for what's called a hemosiderophage in that trach wash. So if there's not a way to scope them at the barrel race, well, you know what, we can do it on a Monday. And if we've got a ton of hemosiderophages in there, then we've got exercise-induced pulmonary hemorrhage.
Yeah.
So it's a really cool technique.
Yes.
You can actually do it in dogs too. We were trying to figure out what was wrong with my dog, and my wife's like, I don't know what. She's a small animal vet for anybody that doesn't know, and she's trying to figure out what to do next. And I was like, well, why don't we just do a trach wash? She's like, oh, you got to have a specialized scope for that. And I was like, well, luckily your husband's a toy freak, so we have one. So.
And I mean, and again, it's nothing really fancy. It's just a regular endoscope with a biopsy port.
Yeah, it's not fancy. It just has to be teeny tiny.
Yes, especially and your dog's pretty big, so
yeah, it was a lab, so I mean, I use one of those little tiny scopes, like the pediatric scopes.
Oh, you use one of those? Okay,
yeah, I use one of the ped scopes.
Oh, okay, so
we have a whole size. We have a whole range of them. It's almost like me and fly rods is me and my endoscope. So. But yeah, so yeah, the great diagnostic tools on the airways, like I said, it's one, and like I said, being able to do the trach washes just right through the scope. It's a 5-minute procedure.
Yes.
We're not poking holes anywhere. We're just using the one the good Lord gave them.
Right. And it gives us even a lot of information just in the moment, too. You can see, where things are. If we've got a ton of inflammation, like more, down lower, I might say, we might be dealing with something deeper in the lungs versus something more kind of up top. And
yeah. Switch over, do a transtracheal wash, a BAL, boom, done.
Easy peasy lemon squeezy.
That's it.
And speaking of washes, we can get into the guttural pouch with that too. Those are some of my favorite and also least favorite. So
I love going in guttural pouches. So the guttural pouch is this little pocket on the side of the upper airway, and a lot of bad things like to hide in there.
It's our prime strangles location.
Yeah. Strep zo, strep equi, those all like to hide in there.
We get some fungi that will go in there and wreak havoc. So
I think one of my favorite things, and it doesn't happen often, but when it does, I still get kind of giddy, is when you pop into the guttural pouch and you've got the chondroids in there.
No.
And that's these little, we call them rocks, but it's pus that's been in the guttural pouch that's gotten dehydrated and squeezed down. It forms these little rocks called chondroids.
They look like rocks, and they come out like rocks. You flush them out.
My favorite is I've got 2 different kinds of baskets, and we can go in there and you can just grab them and take them out.
Pull them out, yep.
It's so much fun.
But it's a good diagnostic tool again, and if we've got horses that have really, bad strangles infection or they have a ton of chondroids, we can flush all that out.
Yeah.
And it's
minimally invasive. We're not having to do surgery. We can do this all through an endoscope.
Yep. It's very nice.
And then, another place, I'd probably say the second most common use of this is when we get into gastroscopy.
Yes.
Looking at stomachs.
Yes.
So it's a different scope. We're dealing with, like, most of these horses, you need 3.5 meters of scope. You can do 3, but
3 gets a little dicey.
Yeah, you've got a lot. You don't realize how far it is from the nose to the stomach until you buried 3 meters of scope.
Especially we start getting into these thoroughbreds, these bigger warm bloods. I did 7 draft horses the other day, and even though I was struggling with the 3.5 meter on some of those Belgians, I'm like, oh.
Yeah.
I'm like, okay, I'm at the end of the scope, and I can just now see the pylorus. Here we are.
And I think that's one of the things that's really changed is when we can get in there and truly diagnose stomach ulcers, we're not guessing our way through it. And especially as the medication for stomach ulcers get more and more expensive, being able to get in there with that gastroscope and know, are we actually dealing with this or not, is...
And seeing how well we're responding to the therapy,
Right.
too. A lot of these ulcers take a lot of time. And so, they say, 30 days of treatment, you're good. I'm like, nah, 30 days of treatment, we're just getting started.
Yeah, you get some of these, like if you're sitting there with these big grade 3s, you may be looking at 60 days on some of these.
Some of these ones, too, on the glandular mucosa, they can take a lot longer to heal as well. And they change shape. And, it's good to know, because if we think, and sometimes I got people and they're like, oh, I've been throwing ulcer treatment at them forever, and I'm like, okay, well let's go in there and see. These horses are clean,
Yeah.
and I'm like, okay, we've ruled out a big problem.
Right. We need to go look somewhere else.
We need to go look somewhere else. We need to stop going down the ulcer route, because that was a lot of money.
Yeah.
We can go spend that money doing something else.
My favorite one I ever had was I was trying to get someone to do a gastroscope, and they didn't want to do it. They just wanted to treat. We're 2 or 3 rounds into treatment, still having some issues. Finally got them to let me do a scope. We do a gastroscope. And normally bots are not a problem. But when they are literally wall to wall in the stomach, and I can't find normal mucosa, the bots are that bad, that's a problem.
Blech.
So we ended up putting a $10 tube of ivermectin in them, and
then it fixed all the problems.
fixed all the problems. So
Yep.
gastroscopy.
Uh-huh.
And again, when we talk about minimally invasive, we're passing the camera through the nose. They swallow the scope. We drive it down into the stomach, inflate the stomach, look around. 10-minute procedure.
Yeah. And we can do it at the farm.
At the farm.
As long as you can fast your horse, we can do it at the farm, and we got our answer.
Yep. And I think we did a podcast earlier on gastroscopy.
Oh yeah,
So,
it's gastroscopy has come up a lot on this podcast.
Yes.
We're big gastroscope fans here. So
yeah, and like I said, you're in and out 10 minutes, minimally invasive, minimal side effects. And when I say minimal, we've done well over 1,000 scopes. When I pulled the record, we've done well over 1,000 scopes here.
really,
Yeah, I guess. Well, I mean, we do almost.
we do a couple a week usually.
Yeah,
So
we do anywhere from 250 to 300 scopes a year in our practice. So I mean, we do a lot of these.
Right.
So it doesn't take long to hit over that 1,000 mark. And I'm gonna knock on wood. I can only think of one time I had an issue, and we just didn't get the air out. Mm-hmm. And once we switched over and got the air out, because that was the thing. If you go back, I show my age here, but if you go back when we were doing these scopes, we didn't know we needed to vacuum all this air out.
oh really?
Yeah, we didn't. That wasn't common.
Oh, you just left them all bloated.
Well, you would just you'd after you got them floated or after you finish the scope, you just pop the biopsy port off, let the stomach contract, and push the air through.
Oh, okay, interesting.
And then we figured out, we should probably put a vacuum pump on
Yeah.
here and actually vacuum this air out. But it just had a little bit of air moving in the small intestine. The horse got painful for about 3 minutes and was fine. Mm-hmm. So
Hey, well, got a little gassy.
now we just put a vacuum pump. We just get rid of all the air.
Easy peasy.
Not an issue. So let's talk about, and I guess another one, if I probably had to say the third most common use of endoscopy, it's probably actually arthroscopy.
Yes. Which is putting it in a joint.
Love that. Uh-huh. One of my favorite things to do.
Yes. And it's been around for a while, too.
It has.
It's, and it's probably started big in human med.
It did start in human med. In fact, when I was at a course, Wayne Michael Wraith, he's the joint guru of the world. And Wayne's, so to give you an idea how long ago it was, I think Wayne turned 80 this year.
Oh, gosh.
And this was back during his residency, and he'd heard about arthroscopy. So I think we're talking about early to mid 80s here. And he heard about a human course doing this. And so he talked to his professor and let him go on. He said there was 100 people in the course. 99 of them were MDs, and here's the one DVM.
Oh, man.
And Wayne went to figure out how to do arthroscopy.
And now it's everywhere.
Oh yeah.
I mean, every major surgical center you have, and even the not major surgical centers, we've got one here.
Yeah, we have one. We do.
Yeah.
But what it does is when you have those chips in the joint, if you have the OCDs in the joint, used to this required complete, like making a large incision into the joint and getting this chip and removing it. It was a major procedure. Now we're making 2 small stab incisions, looking up at a computer screen. We can visualize everything. We move over with our instruments, watching the screen, grab the fragment, clean up the joint. And I mean, these have what was once a major procedures now very minimally invasive. Some people don't even suture the portal site shut. I still suture them, but there's a lot of people that don't suture them shut. They just put a steri strip over it because the portal hole's that small. And 2 weeks later, these horses are ready to go.
I mean, yeah, that's because, again, like when you have these major athletes, like racehorses, where you have to get them back to that track as soon as you can, the smaller the hole, the better.
Right. So, I mean, and to give you an idea, like there's a video on our YouTube, but I had one down in the Caymans that had a fetlock chip that needed to come out. And we were able to use some of our portable, we kind of modified a couple portable endoscopy units that we have. We're actually able to fly this equipment down. And was it ideal? No, but we did manage to take a chip out using an arthroscope.
Right, but because again, there was no alternative.
No, there's no alternative.
No, other than making a much bigger incision
Right.
and going in there manually getting it out. That's not practical.
No. So we can go in, do all this by looking at a screen, 2 tiny, tiny holes. The return to work is much faster with this than it was the old school arthrotomies. So
And they do it in small animal too. That's I remember in school that's how they would do all the TPLOs for the dogs that blew out their cruciates. So yeah, all arthroscopy.
yeah, it's really cool. I love arthroscopy. I don't know what it is, but it's just something about when you get inside the joint, it's like, oh, I like it in here.
Just seeing it all clean and like, going in and taking all the little debris out, like all those little torn little soft tissues. You're like, ooh, it's kind of nice.
Love it. One of my favorite things to do, so I really enjoy it. So, another place I think doesn't get thought about as much, but we do quite a few of them is what's called cystoscopy.
In the bladder.
In the bladder.
In the bladder, yeah. I've done quite a bit of those now. Like I think more than I ever thought I really would. But we use the 1.5 meter scope, and I'd use it mostly for a lot of these horses that are having difficulty urinating, and we've ruled out UTIs, we've ruled out any sort of structural thing that might be causing anything, and so we say, hey, let's go look up in the bladder and see, because it's not common, but some horses can get bladder stones. And horses have a very calcium rich urine. It usually comes from their diet. The horses that are on a lot of alfalfa, they tend to have more calcium in there, and some horses if they just can't handle that, and they will develop these large, basically crystals that form into stones, and that can cause a lot of pain in there. And so horses that have large enough stones, we can go in with a laser and break some of those up, or we can modify their diet to try to decrease the likelihood that they're going to continue these crystals. But it's a really good way to go in and just look around and see things, and it's so easy.
Right.
That is one I typically try to do here, just because we're in a very sensitive area. I usually have to get these guys pretty sedated to do that one, but again, it's pretty minimally invasive. I've only had one that really, really freaked out on me.
Yeah, I mean, and I haven't had one, but I haven't done near as many as you have. But yeah, having one that, because you are going up the urethra, it can have a strange feeling.
They get a little violated, but.
Yeah. But yeah, again, we're not making a new hole. We're just going up the one that's there.
And it's quick, it's easy. I had one that was just giving me a lot of problems for a while, and we weren't sure if it was just a behavioral thing or if it was urine, and the urine was kind of a little questionable because he had lived out west for a while, and soil's very different out there. Horses get these fun little things called enteroliths in their gut because they can, just of the soil concentration out west, and there's some reports that they can get these in their bladder as well. So we went in there just to see if he had anything. He really didn't end up having anything, but it was a good way just to rule it out.
No, it's a great use of an endoscope because, again, you're looking at it. You can visualize the bladder on ultrasound transrectally. You can do a UA, but when you actually go into that bladder with a scope, again, seeing's believing.
Yes.
I mean, you're looking.
And we can look all around and we say we are good, or, oh, we've got something in here.
Right.
Now we need to go do something. And because, again, a lot of those stones, you can't see them on an ultrasound, or you may not be able to feel them until they're huge.
Right. And it's not like small animal. We can shoot an x-ray and say, do we have bladder stones or not?
Right.
Because you can't x-ray that part of a horse.
Not yet, at least.
We're working on it.
We haven't figured it out yet. But
Nerds are working on it. But yeah, it's another great use of endoscopy. Kind of a newer place that we're using it, and I kind of think this is how we ended up getting some of the very small pediatric rigid scopes, and also later on we have the very small pediatric flexible endoscopes is dental care.
Yeah.
So both oral endoscopy and sinoscopy, where it's put in the sinus. The oral endoscope, to me, so when we're evaluating teeth, we look at them visually, but if we need to get a better look, before we have to reach over, grab a dental mirror, like your dentist does. And we're looking through this mirror, and we're trying to see what's going on. Now, we've got a specialized scope just for evaluating teeth. So if we're trying to decide, does this tooth need extracted? Or if it's a more complicated extraction that needs better visualization, we can just pass this endoscope in there. And we can fully visualize everything we're doing. Right.
And, and it makes things easier. It makes us easier to make decisions. Because, again, I think we've talked about this, not all teeth want to be extracted. A lot of, if we can look at this tooth and get good visualization on it from all angles, and we can say, hey, we might be able to salvage this thing. We don't have to go through this big surgery to go get this tooth out.
Well, and I can remember when I was first getting out of school, we pulled a lot of teeth because we thought that if this tooth was fractured, if it had a cemental carie, a lot of different indications, the only treatment we thought we had was we had to extract this tooth. Over time, we've learned to better evaluate these and pick and choose. I don't think we need to extract this one. No, this one has to come out. But having oral endoscopy allows us to better know, to make better decisions. Because I think what we've kind of learned is that tooth is much better in the horse's head than in than out.
Yes.
So if there is a possibility to save that tooth, let's save the tooth.
Yes.
And I think oral endoscopy has allowed us to probably save more teeth than we ever have before.
Or we've had some that they've created a pretty significant sinusitis because there's such a bad apical root infection that now we can take that little tiny scope, make a little hole in their skull, and we can look around in that sinus and see. I remember Dr. Zoe and I, we had a real nasty one that just kept blowing up with the sinusitis, and we stuck the camera in there, and it had basically a giant chondroid, a big pus ball that was just chilling in there. We could see it on x-ray, and we weren't sure what it was, but we're like, oh. And we just, manually broke it down and flushed it for a couple days, and horse never looked back. Yeah,
and used to, the only way to have done that would have been to go in and do a sinus flap.
Right.
And you'd have to, cut part of the sinus out, elevate it up, and then you've got to let that heal. And we're talking about a hole, now we're working in holes with the size of a 16-gauge needle.
Yeah. That's all we did, because we just used a teeny tiny little scope that we could just stick in there and look around, and we're like, oh, there's the problem.
Yeah, and I tell everybody, CT's great. Love us, X-rays are good. CT is great. Sinoscopy, Better than CT.
Heck yeah.
Because you're physically looking at it. You're not taking 2D and figuring out how do I reconstruct this in my mind.
Right.
It's let's put the scope in there and say, yeah, this is the problem. Mm-hmm. Like I said, y'all were able to do a surgery through a endoscope that before was a very invasive procedure.
Yes.
And again, became minimally invasive.
Right. And for this horse, this was an older horse, and doing a longer standing sedation may not have been good for him. And we already knew healing was probably going to be a long time. So this it all really worked out. It was great. But
yeah, and just a quick shout out, Dr. Zoe, if you're listening, we miss you.
We do.
Yeah, maybe one day he'll come back. But yeah, I mean, that was a great use of it. I remember that case, and y'all did fantastic with that because I think y'all were the first ones to do that with the new endoscope.
I think you were out of town. I think it was just the two of us, and we were alone, and we were like, we're just going to try something. We're just going to try something.
Awesome.
And so
it was really cool. And like I said, it allows us to do those things that we could not do otherwise. So, again, oral endoscopy, sinoscopy, fantastic uses of endoscopy.
have you done laparoscopes? Have you had?
No, we're actually in the process of looking at the equipment to start doing some laparoscopes.
Okay.
So laparoscopy or laparoscopes is where we can actually go in and we do abdominal surgery through small portals in the side. I think the number one indication for it is the standing ovarectomies.
Yes.
When I first started doing those, you had two choices. One was a colpotomy. So you went in vaginally and did this. And the other was you made a flank incision. Mm-hmm. And so you'd make this big flank incision, big enough to get your arm in. And I have done a lot of those. And so then you go in through this flank and you have no visualization. You're straight feel. You're pretty sure you have the ovary, not the kidney. And I can remember you're holding on to this ovary. And then you kind of have it hooked on one part of your hand, and then you're feeling around going, okay, there's kidney. So this is definitely ovary, because you don't want to take the kidney out.
Right. Yeah.
And most of the time, you're like, well, the ovary should be much smaller. Well, it should, but most of the time if we're doing this.
If they're getting the ovary taken out, it's usually because it's a problem and enlarged.
Yes. And then you're praying it's not a fecal ball in the colon.
Oh, God.
So you're doing all these things. You have no visualization. Mm-hmm. With laparoscopy, we just go in and look at it.
Yeah.
And again, it's small, tiny portals. Mm-hmm. It's 3 portals, 1 for the camera, 2 for the instruments. Inflate the abdomen with CO2, and go get the ovary out.
Mm-hmm. We did a cryptorchid in school with one. It was very neat, bilateral, just doop doop each side. Yep. Found them. They were tiny, but.
Did y'all do it standing or lay them down?
That one was laying down because I think they were doing something else at the top, and they said, "Well, he's also a crypt. Can you get those out?" So.
Yeah. Well, that's the cool thing. There's been some people working on even doing the cryptorchid surgery standing.
Yeah.
With laparoscopy.
Which is insane.
Yes.
Because you're looking for such a teeny tiny little peanut
in a
very large distance.
But yeah, it's laparoscopy, and there's even been some talk of being able to possibly do some of the colic surgeries.
Yeah, I've heard that.
If it's the right one, to be able to do that laparoscopy, and
which would be like absolutely crazy. And
yes.
I mean, that would like completely change colic surgery because so much of any risk with surgery is the recovery. That's probably one of the biggest risks that we have, but especially these colic surgeries, they are tired. They're usually, very behind on their electrolytes and everything, and their recovery is always so hard on these guys. But if you could take that part away, and that would be crazy.
Well, and I think that's where the future's heading in general, and in all of veterinary medicine, no different than human med, is as our technology advances with endoscopy, these incision sites are getting smaller and smaller. And I mean, I had to have my gallbladder out on emergency, 2 years ago, year and a half ago, and I can remember, 3 portals.
Wow.
3 little portals, in and out.
Popped it out.
Yeah. My son had to have his appendix removed, and it amazed me of how fast they can do these procedures.
Oh yeah.
Again, you're not having to close these up. You actually, I think, in a lot of cases, have better visualization because you're not working down in the abdomen. You are now like in it. Yeah, the camera puts you in the abdomen,
right where you need to be.
Right, and it's the same thing with like arthroscopies. The magnification, the clarity on these scopes has gotten to the point where we can see such little fine details that you can't see with the naked eye.
Right, and you're minimizing your risk for infection.
Yes.
You're improving your recovery times. Like it's, I think it really is the way of the future. Like as far as surgeries, I mean, I feel like they're doing so many things now, and it's cool just watching them. And they got their little, it's like playing little video games with the little scope and everything. It's cool.
Yeah, it's a lot of fun.
It's cool to see.
I keep looking at the humans, like they got the robotics.
Oh yeah, those are.
I mean, that's crazy.
Those are wild.
Yeah, I mean, the surgeon's literally sitting behind a screen, holding on to some things, and that's the crazy part. So, like in the human world, with the internet speed getting where it is, there are times where some of these surgeries, they're getting really close to where a surgeon in Atlanta could be doing a surgery in Miami.
Be like through
the robot,
which is so scary. But
I mean, how?
Man, you better hope that Wi-Fi connection's good.
I mean, I think you probably still want another surgeon in
there
room.
looking at it, but
if it's a procedure, you need a certain guy. Like instead of having to fly that guy in, they're getting to the point where they can sit, basically in their office at a console
and have their little their little Nintendo console there. Yeah.
And I remember thinking, because I was with fiber optics, when I was going down to the Caymans one time to work, the guy sitting next to me on the plane, he was in charge of the internet. Like his job was to get internet to the Caymans.
Interesting.
He was the computer guy that made that happen. And he told me, when you punch a button in Grand Cayman, that signal hits Miami in 0.2 milliseconds.
Wow.
All right, because that's fiber optics. So I hit the enter button, and that signal's all the way in Miami in 0.2 milliseconds. And so with that kind of speed, this remote surgery, it can happen.
I'm telling me telehealth surgery is possible now.
I think it's coming. Now, don't get me wrong. I'm still not ready for that to happen.
That would like. Don't tell me that. If I'm in surgery, don't tell me that my surgeon is on the other side of the continent. That would. I don't need to know that.
Because I do worry about what happens if the power grid goes down.
Yeah, for real. I'm like, ugh.
What happens if somebody decides to take out the internet line going in? So.
Somebody starts downloading a very large file. The internet slows down.
Wrong person pulls up a YouTube video, crashes the internet.
Yep.
Yeah. Not where I want to be.
When you're logged into the wrong feed or something. Yes. Yeah, you're like, oh, nope, that's not her abdomen. Like, oh my God.
So, but yeah, I think it's in equine med, I think you're going to see more and more endoscopic procedures. I think you're going to see more and more diagnostics through endoscopy. We obviously have embraced endoscopy around here, given, I didn't think about it. We probably, we got 3.5 scopes, an arthroscopy tower, the oral endoscope. Yeah, we got seven different
your
endoscopy cameras.
Eyeball one in there somewhere too. So,
have it too. Yeah, the wireless. If we're doing ears and eyes and things like that, it is really.
Yeah, we didn't even get into all the otoscopes and all the little things that they do over in small. I'm like, those are wild.
It's crazy. Well, I originally got one of those otoscopes because it was a tiny fixed rigid scope, and I could look inside a sinus with it.
Oh.
And I was like, oh yeah, and we can use that in small too. It was a small otoscope. And I looked at it one day, I was like, oh, we can put that in the sinus. So I kind of like to say we're doing sinoscopy before it was cool.
It's all about how creative you can be too. I mean, because again, I feel like even how Zoe and I got into the sinus one is we were just kind of spitballing. We were like, well, let's just try it. Like, if it doesn't work, it doesn't work. But like, we didn't have any really other alternatives. So.
You're a local block and a small hole away from
figuring it out. Yeah. And so it's, we kind of just say, hey, if I can put a scope in it, I'm going to try it. So,
and like I said, cross-sectional imaging is fantastic. Mm-hmm. Looking at it on the camera, way better.
Yes.
So, but yeah. So definitely, I think, again, I mean, keep watching. More and more stuff is going to become endoscopic or laparoscopic or arthroscopic. I mean, it's happening more and more.
I think it's just going to become the way to do it, because until we can get better technology to image the full body of the horse.
Well, even I just thought of this. Even the foraminotomies they're doing in necks now.
Oh yeah.
You see, that was a large incision. You had to dissect down. Now they're putting they're doing it laparoscopically.
Yeah.
So they're putting the camera in position, doing the whole thing through a camera feed. So what used to be a very large incision for this neck surgery is now 2 sutures.
Which was crazy. I think I took sutures out for one that you had referred for it. And again, I was like looking up and down the horse. I'm like, where did this thing happen? I thought it said it had this procedure. And then they're like, oh no, it's just these 2 sutures. I'm like, what? Okay.
Yeah, went in laparoscopically.
It was very cool. I was not expecting that. So.
No, it's really cool what we're able to do now. So, but yeah, so I guess kind of sum things up is endoscopy, laparoscopy, all the oscopies. I think they're major players in veterinary medicine. We fully embraced it. I love them.
Yeah,
I love them.
We're fortunate here that we have so many scopes, and we can do a lot of stuff out in the field, and be accessible. And again, we're a little bit wild, and we'll just stick a scope anywhere. So
seeing is believing.
Yes.
So yeah, if you're ever wondering, can you put a scope there? The answer is probably yes.
Yeah.
So if you've got an issue and think you need a scope, let us know or let your vet know.
Pitch it to us. We'll put a scope anywhere.
Yeah,
so.
We'll do it. So, well, thanks for being here today. Thanks for coming in this morning and talking about endoscopy, one of my favorite topics.
Heck yeah.
So
I love it.
So thanks to all our listeners out there. We really appreciate y'all listening. Keep sending us in questions. Keep interacting. I've been told we need to probably do some. I always forget to put a pitch out there. We need to like and subscribe. Is that what it's called, April? Like, yeah. So y'all like and subscribe. So you can
like and subscribe. Share it with a friend.
Yes. So April, thanks for recording this. Casey, thanks for editing everything. Thanks for being here. The whole team here at Countryside Equine. Appreciate y'all listening in. Hope to see y'all soon. Take care.
Bye.